Good morning, good evening, good afternoon, everyone. Welcome to our EPI-WIN webinar on therapeutics in the COVID-19 clinical care pathway. Very happy to have you here. Please introduce yourself on the chat. If you come from all over the world, we'd love to know more about you. So I'm Supriya Bezbara. I'm the team lead for science translation in WHO headquarters. I'm delighted to be here and delighted to welcome you here today. We have with us two very distinguished speakers. We have Janet Diaz, who's the team lead for clinical management in the infectious hazard management unit in the health emergencies program for WHO. We also have Gillian Sachs, who's a technical officer for COVID-19 health operations lab team in the epidemic and pandemic preparedness and prevention department. So Janet will explain the care pathway, COVID-19 clinical care pathway to you. And then Gillian will talk to you about testing, and Janet will then talk to you about the therapeutics. After that, we will have questions. So please put your questions in the Q&A and we'll answer them at the end. Thank you so much. And over to Janet, team lead for clinical management at WHO HQ, and a familiar figure. I'm sure you've seen her also from all the press conferences and other. It's over to you, Janet.
Thank you for the opportunity to present. And just to, I'm going to correct the department I'm in. I'm in the Healthcare Readiness, Country Readiness and Strengthening Department, part of Health Emergencies Program. And I'm pleased to be here to present to you with my colleague, Gillian, COVID-19 clinical care pathway, as you can see here. So just before we start with our content, here is recent epidemiological information reported to WHO as of the 12th of March, and over 452 million cases of COVID-19 with over 6 million deaths. And on the graph below, you can see the different regions of the world with their epidemiological curves. It is important at this moment in time to establish, which I hope you have, but maintain and adjust as new evidence comes out, as new guidelines are published, your COVID-19 clinical care pathways. And here we have, I think it was a couple of months ago, tried to make a more simplified representation of the COVID-19 clinical pathway that takes into account the various different guidelines that WHO is producing, both on diagnostics and on treatments and on clinical management. And here we have it, and this is what we're going to discuss today. So the C is to confirm SARS-CoV-2 infection. So obviously, you know, patients, when they come to see you, people, if they have symptoms of an illness, they're not going to say, I have COVID-19, right? They may actually at this point, but, you know, sometimes it's unclear what, you know, what diagnosis they have or what infection they have. So it is important up front, as in all good clinical care, you have good medical triage, you know, you do your clinical assessments, but then you need to confirm. You confirm SARS-CoV-2 infection, and that requires a test. And so Gillian's going to really go into the guidelines WHO has around that. A is for assess. It is really important. One, we assess symptoms, and that helps you kind of decide which, you know, what is the likely diagnosis the patient has. And in patients with COVID-19, risk factors, what is putting a patient at higher risk for complications or death? And then really assess the severity of the disease. So how severe is the patient? Because we do have different treatment options for different patients with different severity disease. Respond is how to respond. What kind of treatments should you be giving your patient? And again, the treatments do depend on disease severity and the presence of risk factors. And E is to evaluate. That means monitoring the patient during the treatment. So is the patient responding or not responding? And then adjust treatment as necessary. And then through recovery, and we will focus on that at the end. So with this, I'm going to hand off to Jillian, who will take us through the first part of the COVID-19 clinical care pathway. Over to you, Jillian.
Great, thanks, Janet. Next slide, please. So as you all are aware, testing continues to be a critical part of a comprehensive COVID-19 response strategy. We know that testing should be reliable, it should be accurate, affordable, accessible, and we should use tests that provide rapid results. And testing is important for several reasons, both to support individual level case finding, which is most relevant for today's discussion, but also for community level action to inform the overall public health response. So testing enables individuals to know that they're infected. It ensures appropriate clinical care and support to those individuals. It can prevent transmission by empowering individuals to protect their families and communities. And it can enable a better understanding of where the virus is circulating to then inform the overall response. Next slide, please. So since the start of the pandemic, WHO has been releasing evidence-based guidance as well as supportive documentation in order to enable national programs to establish and maintain their testing strategies. So back in January of 2020, we released our first interim guidance on laboratory testing for SARS-CoV-2. And then most recently, last week, we released our newest guidance on the use of antigen RDTs for COVID-19 self-testing. Next slide, please. So when we think of testing for SARS-CoV-2, there's 3 different types of tests that are most widely available. The first 2, which are nucleic acid amplification testing, also known as PCR, and antigen detection testing, are useful for determining when someone is actively infected with the virus, whereas antibody testing is used to screen for whether someone has ever encountered the virus. So when we think about the COVID care pathway, we really are talking about either nucleic acid amplification testing or antigen detection testing. These are also called lateral flow tests. So depending on the epidemiological situation, we also now have guidance that self-testing using antigen tests can also be used for diagnosis. So what this means is that when someone has a positive self-test or a positive antigen test that has been administered by a professional or a positive test by a PCR, all 3 of those individuals should connect to the care pathway and be assessed for further management. Next slide, please. It's also important when we're testing to think about all the many factors that contribute to the accuracy of tests, as well as that contribute to onward transmission when someone is infected. So as a reminder, people who are infected with SARS-CoV-2 can transmit the virus whether or not they are symptomatic. Most people are most transmissible, relatively speaking, around 2 days before they develop symptoms, and then up to 9 or 10 days after symptoms. It's also important to recognize that people with severe disease may be infectious for longer. And the cartoon that I have on the right-hand side here, which was taken from a recent article, just shows you the relative ability of PCR tests versus antigen tests to detect someone who is infectious and who is infected with the virus. So antigen tests are slightly less sensitive, so they may miss some of the people who are incubating the virus or who are less infectious, but they will still detect most people who are symptomatic as well as those who are infectious. And it's important to note that immunocompromised individuals may shed the virus for much longer than those who are immunocompetent, excuse me. Next slide, please. I wanted to just give a little bit more detail on antigen detection tests, since these are the type of tests that can provide a diagnosis most rapidly. So as noted, WHO now has guidance on the use of antigen tests, both by professionals as well as self-tests, whereby an individual tests themselves and interprets their results themselves. Irrespective of whether a professional is using the test or an individual is using the test, We really support the use of high quality antigen RDTs to help increase access to testing and support the overall response. And recently we issued guidance that self-testing provides a way for people to test and make personal risk-based decisions. And again, irrespective of the type of, whether it's a professional test or a self-test, we have recommendations that antigen RDTs should meet minimum performance requirements of at least 80% sensitivity and at least 97% specificity when compared to PCR. And I will note that most antigen tests that are in use have much higher specificity than our minimum requirements here, which is a good thing. There are 5 antigen tests that have been approved for professional use through WHO's emergency use listing procedure. And that emergency use listing procedure will open shortly for review of self-tests so that we can also provide more information on tests that are most accurate and quality assured to inform global procurement decisions. Next slide, please. So the final point I'll just note before handing it back to Janet is it's important to recognize that we all know that the COVID-19 epidemic has been coming in waves. And depending on the epidemiological context, depending on the resources available in your country, as well as your local context, you may need to prioritize individuals for testing. So the highest priority individuals for testing would be those who meet our suspect case definition. When resources are particularly constrained, you could prioritize testing for individuals who are at highest risk of developing severe disease, who are at highest risk for requiring hospitalization, as well as individuals who are symptomatic and already admitted to hospital. As well, prioritizing testing for first symptomatic individuals in closed settings or workplaces, schools, hotels, et cetera, to try to contain outbreaks is important. The next priority is asymptomatic individuals who are at higher risk of SARS-CoV-2 infection. And this might include contacts of confirmed or probable cases, or individuals who are frequently exposed through their occupation, such as health workers. And then the lowest priority would be asymptomatic individuals who have no known exposure to the virus. And I will also note that at this time, WHO still does not recommend any widespread testing of asymptomatic individuals, including through the use of self-tests, because there's limited evidence on the impact and cost effectiveness of this kind of widespread asymptomatic screening. Next slide, please. So just to wrap up, we've listed here a bunch of resources that can provide you with more details on our overall guidance on testing. And thank you for your attention, and back to you, Janet.
Thank you, Jillian. That was great. So now we're going to advance on to the next part of the COVID-19 clinical care pathway. And this is the first section is the A, assess symptoms, risk factors, and severity. So your patient assessment. It is important here to look systematically. One, you should be starting with emergency signs. So if the patient obviously has any signs of being in distress, such as breathing distress, obstructed breathing, severe respiratory distress, cyanosis, shock, coma, convulsions, those are emergency signs and you need to deal with those immediately. So if you're not equipped to deal with those, call for help and then get yourself into the emergency medical system. And if you are equipped to deal with those at your facility, then go on and do your usual emergency interventions. Second is to assess the symptoms. Again, assessing the patient's symptoms helps you understand whether or not patients are having mild type symptoms, or if there are any concerns for any more severe types of symptoms. The symptoms that, again, are concerning for more severe disease include symptoms such as shortness of breath, such as chest pain, such as dizziness, such as confusion. So really looking to see if someone is having any lower respiratory tract involvement, or if anyone is having any neurological involvement. Those are the two organ systems, although people with COVID-19 can have multiple organs involved. Those are the two that you may be able to elicit just by asking the right questions about symptoms. Risk factors. It is key, regardless of the patient's clinical symptoms, to assess for risk factors. It is well established that there are certain medical conditions that are associated with increased risk of progression of disease as well as death. And those include older age, so more than 60 years, and the presence of chronic medical conditions. And there's a long list of these medical conditions that are listed here, such as hypertension, diabetes, cardiac disease, chronic lung disease, cerebrovascular disease, dementia, mental disorders, chronic kidney disease, and immunosuppression. We heard a little bit about immunosuppression from Jillian and the test before. And immunosuppression can include patients with HIV or other or malignancies, or patients receiving immunosuppressive agents. As well, obesity has been associated with severe disease. And here at the end, it says, and unvaccinated against COVID-19. We do know that vaccination really is effective at reducing the risk of severity and death in patients with COVID-19. So if you have a risk factor and you're vaccinated, then your actually risk is lower. But then again, it will depend on your immune response to the vaccine. But so that's why we've stated there, and unvaccinated against COVID-19. Risk factors in pregnancy or recently pregnant women also include older maternal age, obesity, chronic medical conditions, and pregnancy-specific conditions such as gestational diabetes and preeclampsia. Once you assess your patient for symptoms, disease severity, as well as risk factors, we have grouped in our COVID-19 clinical guidelines. We actually have 4 severity classifications, but in this schematic, we do lump the non-severe. So if you start at the right is the critical patients, and those patients need to be immediately identified and emergency intervention started. And those are patients that commonly require life-sustaining treatment, may have diagnosis of acute respiratory distress syndrome, which is acute hypoxemic respiratory failure, sepsis, or septic shock. The patients with severe are patients who are one step below, who have hypoxemia, but usually can be treated just with oxygen, supplemental oxygen therapy, don't need to have advanced respiratory support interventions. These patients tend to have signs of pneumonia, as well as signs of respiratory distress, but not respiratory failure. And then the non-severe, which we do lump into mild and moderate, are those patients that don't have any signs of severe disease or critical disease. And in the non-severe, it's not on this slide, but I am going to comment on it a little bit. One would be the mild patient who has symptoms, but really has no low respiratory tract symptoms or signs. And the moderate may be someone who's got a little bit of a pneumonia, not yet requiring oxygen therapy, but has some sort of lower respiratory symptoms or signs. And here on the right, there's a caution. And the caution here is written because we don't know the perfect threshold for cutoff between severe and moderate. And we've been saying 90% is the cutoff, and that is true, but it could be also that some patients between 90 to 94, which may be this gray zone, if they're patients who are worsening on the worsening part of their clinical presentation, then a saturation between 90 and 94% can be concerning. And those patients may need to be hospitalized for oxygen therapy and close monitoring. So again, this is just a little bit of a clinical tip. If your saturation is between 90 to 94, you must take a careful look at that patient. And if they're on a downward trajectory, or their symptoms seem to be evolving and getting worse, then that patient should have close monitoring and likely be hospitalized. In general, though, those patients with mild disease don't require hospitalization for COVID-19. What about treatments? This is a nice graphic to show you what are we currently recommended in regards to pharmacological interventions for COVID-19. And if you can see here, we have the disease severity lumped at the top, going across horizontally. And you can see non-severe, severe, and critical. And then you can see going from top to bottom in the green is what is recommended. And in the red is what is not recommended. And then if you actually look at the drugs themselves, going through all the color coding here with you, just so it's clear. The green with the drug name is a strong recommendation. So that means WHO strongly recommended those interventions. And then if it's in yellow, those drugs have a conditional recommendation. So if we can see here, then you can see there's a growing list of drugs for patients with severe and critical disease. The first one stated is thromboprophylaxis. So we do have a strong recommendation to use pharmacologic thromboprophylaxis if possible. That would include a heparin agent at thromboprophylactic dosing. The second is for oxygen therapy, which is indicated for patients with severe critical COVID-19. Oxygen therapy is a medicine. It's in the essential medication list. The third is an immunomodulator. The first one we recommended actually for COVID-19 was corticosteroids. And this is a low dose of corticosteroids for at most 10 to 14 days. We also have corticosteroids as a recommendation for MISC, which is the multi-inflammatory syndrome in children that is sometimes seen with patients with COVID-19. Then we have tocilizumab or sarilumab. That's an additional immunomodulating agent. It's an IL-6 receptor blocker. You can use either tocilizumab or sarilumab, and you can add it on to corticosteroids. And the last one in green is baricitinib. That is another immunomodulator. It's a Janus kinase inhibitor. And that one actually you can use as an alternative to tocilizumab. So you start with your oxygen, your corticosteroids, you can give relatively quickly. And then you add on either tocilizumab or baricitinib is the approach. We have two monoclonal antibodies that have had recommendations. One is casirivimab and imdevimab. This is for patients who have severe or critical that have seronegative status, meaning that you would check a serology test, a little bit what Jillian was talking about, but only to see whether or not they had any antibodies. And if they did not, then this is the patient population you could consider to give casirivimab and imdevimab. The only problem here, though, now, and as evidence has emerged, is that this monoclonal antibody combination does not appear to be effective in preclinical studies against the Omicron variant. So you must know if you're dealing with Omicron, this monoclonal antibody it appears not to be working. Now, the other monoclonal antibody we have a recommendation for is sotrovimab. That's a single monoclonal antibody, but that one's only for the non-severe patients. And that is a one-time dose for the non-severe patients. And that emerging evidence for activity against Omicron is positive for Omicron BA1 variant, but for the BA2 variant, showing reduced neutralizing capacity. So we are watching that closely. And the third yellow drug there for non-severe patients is molnupiravir, and that's an oral antiviral agent. And that is a recommendation we published maybe it's 2 weeks ago now. It's the first oral antiviral, and I will discuss a little bit more about that in the next slide. So here, an easy way to look at the treatments, although obviously it's never so easy to go through this entire list. Oh, before I go on, all those in red are recommendations against use, and I will quickly go through those in the presentation. So R is respond with appropriate care and treatments. And just so you know, this is our living clinical guideline. So we have two guidelines. One is therapeutics and one is on clinical management. The clinical management actually goes from an end-to-end approach, meaning from the patient initial evaluation all through their clinical course, through their discharge, and also follow-up through recovery. This is currently getting updated, and we are looking at more recent emerging evidence on heparin and anticoagulants. I wanted to raise that just so you're prepared that we may be revising that current recommendation. And we also are going to be looking at non-invasive ventilation and high flow nasal oxygen as supportive care interventions and prognostic models. This is our therapeutic guidelines. And here, just wanted to show you, if you open up the therapeutic guidelines, either on our PDF or if you go to the MAGIC website, which is the electronic publication platform that we use, you can see there for each recommendation, why we make the recommendation. And in this case, this is the molnupiravir versus standard of care. Hey, and why did we recommend molnupiravir? It's because in the studies that were done, we saw a reduced risk of hospitalization, and that was the main outcome that we looked at for these patients. And the odds ratio was 0.54, so a 46% reduction in the risk of hospitalization of patients who were given molnupiravir compared to standard of care. So here, let's go back, and we're going to go through a little bit of repetition. So just to emphasize, now for patients who have severe or critical COVID-19, again, always make sure if anyone has any emergency signs that they get assessed and managed through emergency intervention pathways and the ABCs. And we don't want to forget that, even though we're not discussing that in detail. For patients with severe and critical COVID-19, oxygen therapy, number 1. Number 2 is corticosteroids, venous thromboembolism prophylaxis, IL-6 receptor blockers, or baricitinib, and supportive care interventions. For patients with mild or moderate COVID-19, no risk factors. So if you have no risk factors, then symptomatic management at home or in the community where you're being cared for. And here, if you have risk factors, non-severe COVID, mild or moderate COVID-19, then here the treatment options include molnupiravir, excluding pregnant or breastfeeding women and children, and we'll go through that in a little bit more detail, or sotrovimab, which is the monoclonal antibody. So maybe too much repetition here. I'm not sure if you're going to have these slides for you, but again, here is the recommendation for oxygen therapy for patients who have severe and critical COVID-19, or any patient with an emergency sign, give oxygen therapy, and here are our targets. Here's our recommendation for corticosteroids. Again, for severe or critical patients, there's not a lot of details on this, but it is a low dose of corticosteroids. You can use dexamethasone or its equivalent steroid dose in methylprednisolone, or hydrocortisone. And the dose length of duration of treatment is 5 to 14 days, but should not exceed. If the patient is discharged from the hospital, then just let them go. You do not need to give an extended course after discharge from the hospital. The MISC recommendations are also include corticosteroids in addition to supportive care. But we did, and here you can see them. And again, for those of you that are working in pediatrics, what is the case definition of MISC? It's the age 0 to 19 years of age, with fever for more than or equal to 3 days, and clinical signs of multi-system involvement, that it's a rash, bilateral non-purulent conjunctivitis, or mucocutaneous inflammation signs, such as in the mouth, hands, or feet, at least 2 of the following, and then the other option is hypotension or shock, cardiac dysfunction, evidence of coagulopathy or acute GI symptoms, and the elevated markers of inflammation, and no other cause of the inflammation, and evidence of SARS-CoV-2 infection with a test. Here we have the thromboprophylaxis. This has also been a long-standing recommendation we've had for COVID-19 since the beginning of the pandemic. And so this is for using standard pharmacologic thromboprophylaxis with anticoagulation rather than the therapeutic or intermediate dosing. And of course, we know that the complications of coagulation clots, blood clots, be it pulmonary embolism, stroke, these have been, these are reported in patients with severe critical COVID-19. So have a good assessment of your patient. And if you suspect someone actually has a clot, then make that diagnosis, and then they would be indicated for higher doses of therapeutics. But in the absence of a diagnosed clot, at minimum, thromboprophylaxis should be given with a pharmacological agent such as heparin. We are currently reviewing, there's been a lot of emerging evidence on different doses of anticoagulation, and we are conducting a prospective meta-analysis, and we should have those results to you for public dissemination relatively shortly, and we'll be reviewing that with our guideline development group. What about tocilizumab? As I've said before, this is for patients with severe critical COVID-19. in addition to corticosteroids. So it does not replace corticosteroids, it's an additive intervention. And why did we recommend this? Because it reduces mortality. And here we don't have the reduction in mortality figures for you, but if you go to the guideline, you can start to see what the incremental reduction in mortality is over the use of corticosteroids. Baricitinib, again, is in addition to corticosteroids. Currently, we are recommending it as an alternative to IL-6. So if you don't have tocilizumab available and you do have baricitinib, then you can use that as an alternative. I also want to acknowledge this is an evolving space. So there is emerging evidence actually that these two drugs, both tocilizumab and baricitinib used together, may be additive as well. But right now in our guideline, we're saying to use one or the other in addition to corticosteroids. The monoclonal antibodies, I did discuss this already. The casirivimab and imdevimab had two recommendations. One was for severe or critical COVID-19 and those that were seronegative because it was additive in its reduction of mortality, additive to corticosteroids and IL-6. And then we had one for non-severe COVID-19 because it reduced the risk of hospitalization. But again, here the complications, the unfortunate loss of efficacy in patients with Omicron variant does no longer allows, we no longer recommend its use in patients that are infected with Omicron. So trovimab, on the other hand, is another monoclonal antibody that has one recommendation for it with non-severe COVID-19 patients. Again, those that are at the highest risk for hospitalization, because that's where you'll see the majority of the absolute risk reduction or the absolute benefit in patients who are the highest risk in reducing their risk of getting hospitalized. And here is molnupiravir. This is an important one. This is a newer oral antiviral recommended by WHO for patients with non-severe COVID-19. Again, for those that are at the highest risk for hospitalization. But this does have exclusion of pregnant and breastfeeding women and excludes children. Why? The reason is because we still need to gather more safety data on this medication. It is new. Molnupiravir works by damaging the viral genetic information. And there is a small theoretical concern of whether or not it could also damage human genetic material, which is why we don't recommend it in pregnant women and women that are breastfeeding or in children. WHO has recommended and is about to publish a pharmacovigilance study program. So that is going to be live soon, and I think in the next couple of days, which will allow member states, when they roll out molnupiravir in their communities, to also roll out a pharmacovigilance study so that we can gather more safety data. And if we can gather more safety data in larger numbers, then we'll be more confident about the profile of this medication. As important as it is to use the right medicine at the right time for the right patient, it is important not to use medicines that we know are not going to be effective or may actually cause undue harm. So for example, we do not recommend antibiotic therapy, prophylaxis, or treatment for patients with mild or moderate COVID-19 unless there's a suspicion of a bacterial infection. So why is this important? Because we want to reduce antimicrobial resistance. Overprescribing antibiotics for viral illnesses is not what we want to do. That may cause more harm than good in the long term and has no indication in patients with COVID-19. We also have strong recommendations not to use hydroxychloroquine, lopinavir, or ritonavir, and for patients with COVID-19, regardless of the disease severity. And I'm going to focus a little bit on remdesivir right now because it says here, don't use remdesivir, and we do have a recommendation for that currently. But we are and have reviewed newer evidence for remdesivir. There was a recent trial in outpatients, so just in non-severe COVID-19, that actually had some promising results in reducing hospitalization. So we have not yet published that guideline, but expect a revision in the recommendation for remdesivir upcoming in the next month. And we do not recommend the use of ivermectin in patients with COVID-19, except in the context of a clinical trial. This applies to any patient of any disease severity and any duration of symptoms. This is because when we reviewed the evidence, which is now many months ago, it was very low certainty evidence, and we thought should be tested some more, but not be used for treatment of COVID-19. Similarly, we have a recommendation against the use of convalescent plasma for the treatment of COVID-19, except in the context of a clinical trial for patients with severe disease. This was because we still think maybe there can be a benefit in this most severe patient population, but the clinical trials need to continue and making sure that we use consistent dosing of the convalescent plasma, because there was much variability in the dosing used for convalescent plasma trials during this pandemic. And we have a recommendation not to use ruxolitinib or tofacitinib. Those are also Janus kinase inhibitors, similar to baricitinib, but a little bit different, which is why we didn't make a whole class recommendation. We decided to look at them individually. And until there's more data about these two drugs, we would say not to use them and use baricitinib when you have, if you have that available. Evaluate response and recovery. And this is reevaluation, recovery, and rehabilitation. It is important to monitor all your patients that are being treated for COVID-19 regularly. That depends on where they are. It could be in the hospital, you do normal clinical monitoring in the hospital, or if you're in the outpatient setting, regular outpatient monitoring of the patient as well through their recovery. At any time, if the patient seems to be getting worse or have any emergency signs, follow your usual emergency care pathway interventions, call for help. Make sure to reassess treatments. It could be that the patient started off with mild or non-severe COVID-19 and then progressed and developed more severe disease. Then reevaluate what treatments should I be giving the patient now. Is it important to add on a new treatment such as corticosteroids if the patient goes on to develop severe pneumonia? But it is important that any treatments be done under medical supervision. So either in the outpatient setting or in the inpatient setting, that the treatments are delivered under medical supervision and that treatments are completed. And if you're caring for patients in the outpatient setting, make sure you advise your patients to monitor for any worsening of the symptoms such as chest pain, trouble breathing, fast heart rate, and if present, instruct these patients, again, to call for help according to national protocols. What we are concerned about is the post-COVID-19 condition, or long COVID. And it's becoming more and more apparent that a significant proportion of patients who get infected with SARS-CoV-2, who develop COVID-19 infection, regardless of the severity, may go on to develop long COVID or post-COVID-19 conditions. So this is persistent or prolonged symptoms after the initial episode. Here, I have for you the definition of post-COVID-19 condition. And usually the diagnosis is usually made 3 months from the onset of the acute COVID-19. So we do know people can have protracted illness, but at 3 months or more is when we start to think you have long COVID. And these symptoms last for at least 2 months and can't be explained by an alternative diagnosis. Common symptoms include fatigue, shortness of breath, cognitive dysfunction, but also others. As many as almost 200 symptoms have been described. But these impact, and what the common thing amongst all these symptoms is that they impact on everyday functioning. The symptoms can be new onset after the initial recovery from an acute episode of COVID-19, or persist from the initial onset, and they fluctuate or relapse over time. We are currently working on whether or not a different definition needs to be applied to children, or how to make sure that this captures children who may also go on to develop long COVID. We have a few recommendations in our current clinical guideline that's currently getting updated. The recognition part is that you must, assess your patients, monitor them for resolution of their COVID-19 acute symptoms. Always counsel your patients if they develop anything that's life-threatening, that they should seek care for those. There is some recent publications about the cardiovascular complications after acute COVID-19. It's important that patients are counseled that if they develop any sign or symptom of a life-threatening cardiovascular event, that they seek care immediately. And also those patients that have been in intensive care units, the development of post-intensive care syndrome, something that was well described before COVID-19, that those patients receive the appropriate care for that. For patients that go on that may develop long COVID or post-COVID-19 condition, patients should be cared for in a coordinated care pathway, care model, which includes primary care providers, relevant specialists, depending on the symptoms the patient may have. That could be a neurologist, it could be a cardiologist, it could be a pulmonologist, it could be a rehab specialist, mental health specialist. But this needs to be done in a coordinated way, usually coordinated by the primary care physician or clinician, and accessing the specialists as needed. Everything needs to be catered and tailored to the patient's needs. And in addition, management at this moment in time, even though we don't have one drug for post-COVID-19 condition, we have self-management techniques that, again, we can indirectly apply to patients with long COVID for symptom management, such as the fatigue management, insomnia management, or the cognitive dysfunction management, and as well as rehab interventions. WHO is currently reevaluating these guidelines in order to update guidelines on management as well as rehab interventions for post-COVID-19 condition. Although we don't know the exact numbers, there is an estimate range of about 10 to 20% of people who experience persistent or new onset of symptoms after SARS-CoV-2 infection. Again, it occurs regardless of disease severity, so it can happen if you have mild disease. And who's at increased risk? I think we still don't have enough information about this, but some early evidence shows possibly female gender, people who had previous poor health, previous poor mental health, those that are overweight and have had asthma. And right now there is some evidence emerging as well about the impact of vaccination on post-COVID-19 condition, and that potentially it could be mitigated with vaccination, either before your acute infection or after. It's really important to recognize these patients, to understand the burden of disease, and research activities around this topic is extremely important to better understand so that we can actually develop more targeted interventions. Here is a list of our comprehensive guidelines that informed this presentation: the therapeutic guideline, the clinical management guideline, also available in the B&J and on the Magic app, and then drugs to prevent COVID-19, our training, our website. You can actually look at our website and see all this posted easily on the website. And then if you're interested in looking at the meta-analysis or the systematic reviews on these drugs, it's live on our WHO website, a link to this COVID network meta-analysis where you can get up-to-date information on the different drugs and understand what's being, what the current assessment shows. So with that, don't forget to protect yourself, keep your distance, wash your hands, cough and sneeze into your elbow, get vaccinated when it's your turn, wear a mask and ventilator, open windows. And again, the best treatment for COVID-19 is prevention. And it's better to prevent disease than to, if possible. But if you get COVID-19, make sure you know that there are treatments. We have care pathways and implement those pathways. So thank you, and over to you, Supriya.
Thank you very much, Janet. And thank you also, Gillian. Thank you for an excellent, very comprehensive overview of WHO's recommendations on the care pathway and the new therapeutics. And in Gillian's case, also the testing. And that was also, what's important, what you've also highlighted is the therapeutics based on the situation, which is very important. And the other thing that struck me is also it's evidence-based. So as the evidence changes, it's, as you said, a living guide. So we adapt accordingly. There are quite a few questions in the chat now. I think I'll start with there's a question on symptom screening, and does it hold good for variants like Omicron, which is, I think, milder. Let's start with symptom screening.
It's a really good question. We do, and we haven't updated our symptom list with Omicron formally, but we do know that evidence is showing that the symptoms may be a little bit varied with Omicron, maybe more upper respiratory tract symptoms than the lower respiratory tract symptoms. But that makes sense, I think, because we do know Omicron is associated with less severe COVID-19 disease. So I think, so the symptoms still matter, but I think you have to be holistic in your symptom assessment, meaning that you have to ask for upper respiratory tract symptoms, right? And that would include sore throat, runny nose, etc. And you have to include symptom assessment for your lower respiratory tract symptoms, so chest pain, shortness of breath, because those are the ones that we would be concerned about having severe disease. And then the fever, how common the fever is with Omicron versus the other variants, I can't say. I don't have all that data ahead of me, but we are looking into that. And again, so I think it's a really important question, is the symptoms, but symptoms still hold true. And I think asking a good set of symptoms in your screening and when you evaluate your patients is important.
Thanks, Janet. Then there's another question. Is there any guidance on the ADSM for COVID-19 therapeutic drugs?
Okay, so active drug safety monitoring. So, our colleagues in the pharmacovigilance and drug safety department here, part of MHP, Medicinal Health Products department, are working on this, and they have various mechanisms in place. So maybe we can just put in their website to that website, and also we want to do active pharmacovigilance, drug safety monitoring for the new antivirals. And WHO has developed pharmacovigilance study protocols for molnupiravir, and we'll do the same with nirmatrelvir, ritonavir. So for the newer ones, that will become publicly available. So let's put a link to that website so that the colleagues can follow up there.
Thanks, Janet. We'll share the link as well with all the registered participants. Another question, could you give your opinion on Paxlovid and COVID-19?
Yeah, so Paxlovid, with the name, the generic name of it is nirmatrelvir, ritonavir, is another oral antiviral. And we have looked at the evidence on Paxlovid, nirmatrelvir, ritonavir, and we will soon be publishing a guideline. The evidence looks quite good. It's a promising agent. So I do think WHO will be publishing a guideline on its use soon, probably in the next 3 to 4 weeks. The risk profile of nirmatrelvir, ritonavir is the only part that's that we're going to make sure that is very clear in our guidelines is about the drug-drug interactions that can be seen. So it won't have. It has still some safety considerations around its use, but the efficacy looks promising from the trial data that we have reviewed.
Thanks. There's a question also on monoclonal antibodies. Janet, would you introduce effect of monoclonal antibodies for patients in severe or critical stage?
So there was just one study of monoclonal antibodies done, and that was with casirivimab and imdevimab in severe critical, and they restricted it to patients who were, they gave it to all patients severe critical, but the subgroup that showed the benefit and mortality was not all patients. It was actually, the efficacy was limited to patients who were seronegative at the moment when they got randomized and treated. with casirivimab and nivolumab. So there does seem to be a role in those patient populations. Again, the only concern now with casirivimab and nivolumab is its lack of efficacy against Omicron. But the role of a monoclonal antibody, be it another one at that point in disease, I think needs to be further studied based on what showed very promising results for casirivimab and nivolumab.
Right. There's a question which is not clinical, but I think relevant. There's a wealth of WHO advisories and scientific evidence, but how do you make sure it reaches the concerned frontline worker? What are we doing to make sure that we reach the frontline workers?
So no, I think this is one of our biggest challenges. So I think if anyone had any recommendations for us on how we can do this better, we would be open. We try to disseminate our products in different venues. One is, the standard guideline. We have publication platforms, electronic publication platforms. We have journal publications. We converted into, for us, we've done the COVID-19 Therapeutics website. So that's a live document with a clinical care pathway we think is relatively simple to read and to use. We are transforming our materials into open WHO training modules. But again, I think getting the information out, because this we believe is trustworthy information, it's evidence-based information. So we do want to disseminate it, but getting it out to the frontline worker, we do want it to get incorporated into national guidelines. So how can we better get it incorporated into guidelines at the national level, and then improving access as well? Because I think it's not just the guideline, it's also access to the life-saving treatments. So a lot of work to do there, but if anyone has any better suggestions on how we can do this, but I think we're trying to use all sorts of technology as well as product line development.
Thanks, Janet. I think that's a very relevant question. Also, on our front, we do coordinate with colleagues like Janet and produce regular EPI-WIN slide sets, which are sent to country offices and is also on our website. That's one of the various platforms we use to reach out to national level counterparts. And then hopefully there's a cascading effect and it leads to frontline workers, but that's something we need to look at. There are other questions. We have 5 more minutes, but there's a question on the role of favipiravir as well as also corticosteroids on mild patients. So 2 different questions.
For the corticosteroids on mild patients, we recommend not to use corticosteroids on mild patients, at least not to use systemic corticosteroids. There is some data, there's been some studies on inhaled corticosteroids for mild patients, but we're still reviewing the evidence. It hasn't looked as promising to us, so we have not written a recommendation for that. But currently against the use of corticosteroids in mild or moderate, non-severe patients, concern is harm, that you can actually do more harm than any good, which is the reason behind that recommendation. And favipiravir, we don't have a recommendation for that. Again, our early look at the evidence was did not seem promising, so we have not gone through the process of writing a recommendation for favipiravir.
Thanks. Then there's a question on, if you don't have access, in many countries, they don't have access to monoclonal antibodies. What do you do then? What options do you have?
So again, right now, I do think we're in a place where we have options. We have lots of options, and it's growing, and it will grow over the next couple of months. So for severe critical, I think it's clearly corticosteroids, IL-6 receptor blockers, or baricitinib. And for mild moderate, now we have oral molnupiravir, although it's limited in its scope of patients that can receive it. And then you have the monoclonal antibody, such as sotrovimab. Again, we are working on access to drugs, not just monoclonals, also to IL-6 and to baricitinib, which have had some limited access, unless your country already uses it for another indication. So we are working on improving access through the ACT-A partnerships with WHO.
There's another question on COVID-19 infection in vaccinated. What do you do if someone's infected in spite of being vaccinated?
So it's a good question. So we do know the vaccine is extremely effective for reducing severity of disease and death. So it's effective. However, you still can have a reinfection, but that infection tends to be mild in nature. So again, I think if you go along the pathway, hopefully you're at lower risk because you've been vaccinated, you have mild symptoms. So it'd just be symptomatic management. We wouldn't necessarily consider you for any of those drug-specific treatments. It could be, though, if you are concerned that you have some immunosuppressed condition where your immunity may not have boosted as well with the vaccine, that your clinician or you as a clinician may consider giving one of those therapeutics to prevent hospitalization and progression. So it depends on the clinical situation, and if there's any concern that your immunity may not you may not have responded well to vaccines.
Thanks, Janet. One last question. We have 2 more minutes to go. If there is a non-severe COVID-19 patient with high D-dimer in 10 days post-COVID infection, is there any place to still give anticoagulation therapy?
So I'm not sure. We don't have evidence to do that. So I think a lot of the thromboprophylaxis evidence is in patients in the hospital with severe critical, and usually thromboprophylaxis is during the hospitalization. I think you'd have to look on a case-by-case basis, but we wouldn't use D-dimer as a sole indicator for determining that. I think it's the risk of the patient, and usually it's reserved during the hospitalization, the thromboprophylaxis. But it's a good question. There's a lot of mechanistically, we do know, coagulation abnormalities are seen with severe and critical COVID-19, and maybe even with long COVID and post-COVID-19 condition. But we have to look carefully at the safety of that, including bleeding as a risk if you use anticoagulants, even at a low dose when they're not indicated.
Thank you very much. And with that, I think we have to bring this webinar to an end. There's still questions coming in, so obviously this has generated a lot of interest. Thank you very much for the questions, and we'll do our best to respond to them, as many of them as possible. Thanks very much to Janet and Gillian for taking the time to present this important issue and to answer some of the questions here from the participants. Thanks to all the participants from all over the world. Very interesting discussions going on there on the chat, I can see. And thanks finally to also our interpreter who's interpreting this in French, and all colleagues involved in this webinar, especially Catherine Sheridan, Judith Van Holten, Vanessa Cramond, who've been doing a lot of work in the background, and the EPI-WIN team. And I hope to see you soon on the next webinar. Thank you so much, Janet.